And we are live. Hi, guys. It's Nathan and Jessica. Cristina is unavailable. She has recorded her sections, and we will play them along with the PowerPoint. Hope that you guys enjoy. Take it away, Jessica.
Okay. All right, let me get my screen shared here, guys. Maybe. Okay. Can you see it?
I can. Yep.
Okay. So we're going to start with one of Christina's recordings.
Anterior cruciate ligament injuries, a comprehensive treatment approach. Nathan Brasser, Jessica Coots, Cristina Swanson, Indiana Wesleyan University, Evidence-Based Medicine, November 2016.
Okay. So now on to my part. We looked at Lely's test for our first PICO for the diagnostic accuracy. Our PICO question was, in athletes with acute knee injury, is Lely's test, which can also be called lever sign test, is it more accurate than anterior drawer, pivot shift, and Lockman test? So the tests that we're all used to using right now. And is it more accurate in diagnosing an ACL injury? The population we were looking at was athletes with acute knee injury. We were investigating Lely's test, comparing to the other special tests, and then our objective was finding the accuracy in diagnosing ACL injury. And here's the reference for our article. It's the arthroscopical and radiological correlation of lever sign test for the diagnosis of anterior cruciate ligament rupture. So for starters, what is Lely's test? I don't know about you guys, but I never really heard of Lely's test before now. So just to perform Lely's test, you're going to have the patient on their back in the supine position. You're going to place your fist under the proximal third of their calf on the leg that you're trying to look at. Their heel should be in contact with the table, and then you're going to take your other hand to apply a downward force on their quad. If you have a positive test, that's going to indicate an ACL injury, and it's going to result in the patient's heel just not moving, and it's going to stay in contact with the table. If you have a negative test, so there is no ACL injury, then you're going to see the lower leg and the foot move off of the table. And I have a really good video to show that. Should be nice and short. Let me unmute it real quick.
Stress the quads and heel pops up off the ground. All right, now moving to the ACL deficient knee. We know it's deficient because we have an MRI. I'm going to put the fulcrum again about 3 finger widths below the tibial tuberosity. Now I'm going to apply pressure to the femur, and the heel is going to stay on the table. Good, thank you.
All right. Okay, so the overview of our study that we looked at for our PICO. The objective was to determine the sensitivity of Lely's test compared to all the other special tests we normally use. Their methods, they had 117 patients between the ages of 17 and 45, and the requirements were that they all had to have been diagnosed with an ACL injury, and they were going to undergo ACL reconstruction surgery. The only downside with this study was that there wasn't a control group. All of their ACL tears were confirmed during the arthroscopic surgery. And with this, 2 clinicians performed each of these special tests on every single patient. They did it pre and post anesthesia. So this was all done in the operating room, but the clinicians were blind to each other's results. So they didn't know who got positive and who got negative for which. So as you can see, these were their results for positivity with each test. In the article, it doesn't say how they got these numbers. It just gave us the percentages. But as you can see, Lely's test definitely had the most positive results out of all the other special tests. So the authors concluded from that Lely's test is far more sensitive, and that they also believe that it's a very easily applied test, so you can use it pretty easily in your own clinical practice. Since it is a newer test, though, they recommended that more future research was needed to confirm these results. Okay, and this is kind of small, guys, sorry. But for our clinical applicability, we got some different numbers than they did, mainly because since we didn't know how they got their percentages to begin with, we were using numbers that we got off of a table that they had presented, and all of our calculations are on there. So our lever sign tests were right here for our sensitivity. We had an 85.71%, which was not as good as Lockman's. The same with our lever sign test. Lockman's, again, was better for specificity. And then for our Pedro score, we gave it a 4, just because since there was no control group, we didn't really meet a lot of the criteria for the rest of that Pedro scale. And then same reasoning for our CEBM evidence scale for only giving it a 3. Just, again, no control group, so it just wasn't really that strong of an article. However, we do believe that this does seem like a pretty good special test that we can easily integrate, and that you guys should be able to easily integrate as well. But we definitely need to keep an eye on the research and just kind of see if it agrees with what they've been saying. You're up, Nathan.
Thank you, Jessica. So my section was on proprioceptive exercises, the therapeutic PIC code. Next slide. So our PICO question was, in athletes following ACL reconstruction and proprioception or proprioceptive and balance exercises more effective than traditional ACL rehabilitation programs in increasing proprioception? So the PICO was broken down. Our group that we were looking for were athletes following ACL reconstruct. We were looking at the proprioceptive and balance exercises versus traditional ACL rehabilitation program, and to see if there was an increase in proprioception. The article that we chose was the following one here underneath the reference: the effect of proprioception exercise on functional status in patients with anterior cruciate ligament reconstruction. The objective that the authors had in this was to compare the proprioception in patients with anterior cruciate ligament injuries, and to assess the effectiveness of an exercise program that consisted primarily of proprioceptive exercises addressing pain, proprioception, and the functional status of the ACL reconstruction. The methods, there was 2 groups. The first group was 20 male patients. 18 were athletes that sustained a injury, comparing the control group of 16 healthy volunteers of the same sex, age, and demographics. One note that the authors had decided was that they were also going to look at the dominant side effects with ACL. So the control and the treatment groups were similar in that effect also. Both groups were assessed pre-surgical and post-surgical 6 months after the rehab was done. The 20 males injured knees were also compared to the unaffected knee, or their unaffected knee, and to the control group at both intervals. The authors evaluated pain, knee proprioception, and functional status. They used a isokinetic dynamometer to evaluate the proprioception and stability of the knee post ACL injury. The results, the authors reported a pre-operative proprioceptive loss in the affected knee compared to the unaffected knee and to the control group. They found no significance post 6 months. The significant improvement was found in pain, severity, proprioception, and functional capacity after 6 months rehab program. The preoperative proprioceptive loss was detected on the patient's injured side compared to the uninjured side and the control group. So the numbers, they assessed the individuals at 30 degrees and 70 degrees. The numbers at 30 for the injured side was 4.95 with a plus or minus of 2.05 on the injured knee compared to the uninjured side at 0.96 plus or minus a 0.52 with a P interval of 0.00 compared to the control group of 1.01 plus or minus 0.0 or plus or minus 0.73 with a pre-P or a P interval of 0.00 and post P interval of 0.16. This is important to understand because when we reported our findings on the next screen for both the 30 and the 70 degree, we looked at the post surgical 6 month compared to the unaffected, which brought it back to almost a wash if you were just looking at post numbers compared to the control group. But it was significant because you had a 3 to 4 point change from preoperative to postoperative compared to both the uninjured leg and to the control group. So the injured knee pre-op and post-op surgical repair at 70 was 4.08 plus or minus 2.46 compared to 0.08 plus or minus 0.42 with a P interval of 0.00 compared to the control group of 0.98 plus or minus 0.4 or 0.54 with the preoperative P interval of 0.1 or 0.00 and postoperative equaling 0.06. And when we looked at it, we were looking more at the numbers of pre versus post on the injured, comparing it to the uninjured leg and then to the control. So again, when we did this for Andrew, we kind of didn't make that clear that the numbers should have been from preoperative to the control group to show that post-operative 6 months that there was a big change and that the rehab program that they had put together was effective to bring them back to almost pre-injury range numbers. So we reported a 95% CI for proprioception between the injured knee and postoperative and the control group at 30 degrees of negative 0.36 to 0.48, and at 70 degrees a negative 0.29 to 0.41, and a 95% CI injured knee post-op to group or post-op group to the control group at 70 degrees of negative 0.14 to 0.5. We agreed with the author's conclusion that the rehabilitation program, predominantly consisting of proprioceptive exercises, provided considerable improvement on knee proprioception and functional status from pre-surgical intervention to post 6 months rehab post-surgical repair. The Pedro scale, we gave a 5 out of 11. There was some major flaws with this study. None of the participants or the physicians or anybody looking at the study were blinded. The same physician did all 20 surgical repairs. They don't say anything about the rehab as far as who did it or did they know. The participants were part of this study. So there was a lot of information missing for the Pedro scale that would have given it higher. And for the same reason, we're using a lower score of a 3 or even a possibly as low as a 4 on this grading scale for the C-beam. For the same reason, it was just a lack of blinding, and the number of patients should have been a higher number. The other way that they could have done this is they could have taken half of the operative or treatment people and compared them to a regular ACL rehab that they would have normally done. And I think that would have given us a little bit better results. So the rehab program consisted of 5 stages. The 3 that we really needed to kind of look at were the inner stage, 3 to 5 weeks. They're starting some proprioceptive exercises, such as the 4-directional balance exercise on a single leg, 30-second heel walks, 30-second toe walking, walking in a straight line with eyes closed, and walking backwards with the eyes open. The next one was the early functional stage at 6 to 8 weeks. They had them drawing figure 8s with the toes, jumping down off from a 15-centimeter high platform, and they started doing wobble board balance exercises. The late stage, 13 to 19 weeks, they were having them do trampoline exercises and wobble board balancing exercises. And then they started plyometric exercises such as bouncing and vaulting. So this video here is just kind of showing one of the plyometric exercises where you're standing on one single leg, bouncing straight forward and backwards. This is a great exercise for helping build that proprioception both in the ankle and at the knee joint. The next one is a demographic of what a jump box that they had described would be. Basically, you're taking 2 feet, you're jumping straight up on that box, and then jumping straight back down, really working on that form. And then the next plyometric single leg is the single leg hop. They're going side to side, and then they'll show a demonstration of going forward that really works that proprioception both at the knee and the ankle, showing that it is a closed kinetic chain. Let's skip this one just because of the length of time.
Okay, and here's Christina's part.
Athletic trainers frequently use electrical stimulation as a treatment following injury. We examined an article looking at patterned electrical neuromuscular stimulation, also known as PENS. Our PICO question is the following. In athletes with acute knee injury, does patterned electrical neuromuscular stimulation, or PENS, improve quadriceps activation? PENS is a novel treatment, and we thought this would be interesting to examine. The article we examined was titled Influence of Patterned Electrical Neuromuscular Stimulation on Quadriceps Activation in Individuals with Knee Joint Injury by Glaviano, Langston, Hart, and Saliba, published in the International Journal of Sports Physical Therapy in 2014. In this study, the authors examined the effect of a single treatment of PENS on quadriceps activation and knee extension torque. They used a double-blinded randomized control laboratory study design. There were a total of 18 subjects with a history of knee pain or knee injury. They were divided into 2 equal groups, either receiving the PENS treatment or a sham treatment. The results of the study showed that there was no differences in the change source for MVIC or CARS between pre and post intervention for the PENS and sham group.
PENS is gentle and effective, accommodating a wide spectrum of patients from elite athletes to aging adults. PENS utilizes neural drive to facilitate muscle strengthening while re-educating nerves and muscles. Other NMES waveforms seek to improve muscle strengthening through forceful, often painful contractions using firing patterns that have little in common with normal body function. The OmniStim FX2 features multiple operational protocols for a wide spectrum of clinical applications, as well as new treatment opportunities.
All right, so that was just a short video that she included to explain what PENS is.
In this study, the PENS treatment was administered with an OmniStim FX2 Pro electrotherapy system. The treatment used 2 channels and self-adhesive electrodes. Channel A was used with 2 electrodes placed over the anterior thigh, over the proximal vastus lateralis and the distal vastus medialis obliquus. Channel B was used for 2 electrodes placed over the posterior thigh, over the distal hamstring and the proximal hamstring. Treatment duration was 15 minutes.
And just since it's kind of hard to see because the pads blend in with his leg, there's a pad there, a pad there, and a pad there, and a pad there.
When we are examining a study, we want to look at if the results are valid. In this study, participants were randomly assigned to groups. The groups were similar at baseline with no statistically significant differences. Both groups received the same assessments. The only differences was that the treatment group received PENS while the other group received a sham treatment. All participants were accounted for, and the clinician and investigators were blinded. Participants were given different instructions on how the treatment may feel based on what treatment they were receiving. The numbers needed to treat for subjects with ACL reconstruction for the PENS treatment was 5. The numbers needed to treat for subjects with anterior knee pain was -5. We examined the confidence interval for MVIC between PENS and sham. With this, we found that number crosses 0, and it's not incredibly large. It's about one-digit span, so there may be a little bit of significance. However, when you look at the confidence interval for the central activation ratio, or CAR, for PENS versus the sham group, that number, while it crosses 0, is very large at the negative 2.22 to 7.82. And that is showing us that that treatment is probably not clinically significant, and we need more research on this PENS treatment before we would want to use it in clinical practice. We examined the differences between the sham and the PENS group, while the authors examined the differences between the pre and post intervention. So we have different numbers than they do. However, we still have the same conclusions that more research is needed. From a clinical perspective, we feel more research is needed before we would want to use this treatment in clinical practice. While the authors did not find any significant benefit for PENS, no potential harm was noted either. The Pedro score for this article is a 10. However, the CEBM level of evidence is a 3. This is due to the fact that this was a single session study with no follow-up, even though this was a double-blinded, randomized, controlled trial.
And then that's references. That's all we've got.
That is all we've got, ladies and gentlemen. Thank you for your time. Hope that you guys enjoyed.
Bye, guys.